So this program is called Horos. It's it's like Osirix, and it's free. This is what I do. So I have my monitor set up like this. For those of you that may care to know, I kind of do this. Okay, so this is just my work list. Okay, and when you click this Osirix button, it pops over here into this workstation, and then you can just then open this up to view it. Okay, here we go. So we've got a 3 views. Okay, I'm going to turn mine up. So first thing I'm going to do is I'm going to do this. I'm going to go. We got a right lateral view, got a left lateral view, and we got a VD view. Now I'm seeing this for the first time. Okay, so it's game on. This is a 2-year-old male neuter domestic short hair presenting to an emergency and critical care service for evaluation of ingestion of a foreign object. Per the owner, possibly ate a party banner, vomiting after breakfast. So some of the questions, good questions. Time frame since the last ate. Doc Angela is worried about why the stomach is full. Dr. Curtin is just is all over this with her interpretations, which is great. So Graham, time frame since last consumed normal food. I don't know. That sort of nice bit of information would be too helpful. 3 radiographs dated November 19, 2023 period. New line. The caudal thorax is normal, period. The liver is normal, period. The kidneys are normal, period. The left limb of the pancreas is normal, period. The spleen is normal despite being visible in the ventral abdomen on the left lateral view, period. The urinary bladder is small and filled with fluid opacity, period. The intra-abdominal urethra is not pathologically distended, period. The stomach has a small amount to moderate amount of amorphous soft tissue with admixed gas, period. The colon contains a small amount of formed feces and gas, period. The majority of the small intestine is empty, period. However, there is a segment of small intestine in the mid-abdomen that is mildly pathologically distended with gas, period. The loop measures less than 1.2 centimeter in diameter, period. The loop has a normal course, period. Abdominal serosal detail is adequate, period. 1 period, small to moderate amount of gastric content dash. This appears to resemble recently ingested food, period. Admixed foreign material should not be excluded given the history of dietary indiscretion, period. New line 2, period. Segmental enteropathy dash. A small intestinal mechanical obstruction is not definitively present at this time, period. Given the segmental distribution, the presence of gastric material in a vomiting patient and the propensity for dietary indiscretion, consider 6 to 8 hours of fasting, supportive care and repeat abdominal radiography, period. This can help determine if there is any delay in gastric emptying, period. If this is declined, consider follow-up abdominal ultrasonography if there is no improvement within 24 hours after starting supportive care, period. Okay, so I'm done. That's what I think. And then, as you do, I sometimes will just kind of double check. So this is the loop that bothered me. Small intestinal loss of serosal detail in the mid-abdomen. I think here, one of the things you have to be wary of is the splenic tail is here. And if you got the splenic head, I can't really see it, but I know that it's x-axis right here. So that means the whole sort of body and tail is through here. So when the radiograph goes through this cat and hits the detector, it's just traveling through more soft tissue in this abdomen, in this section. And so it's just going to have more attenuation of the x-ray beam, and it can kind of look like you've got a loss of serosal detail. I was just looking at this loop right here. It kind of looks a little... So the kidneys are fine. It's a young patient, so they tend to have younger patients in general have larger kidneys. Intact animals have larger kidneys. Intact cat, which this cat is not, is intact cats can have larger kidneys. This is the transverse colon. So I think what I'm going to do is I'm going to fudge this a little bit. I think what I'm going to do is maybe recommend an abdominal ultrasound now. Consider abdominal ultrasonography at this time period. On the VD view in the right cranial abdomen, superimposed with the ascending and transverse ascending colon, there may be corrugated small intestine, period. Amorphous soft tissue occupies the pylorus on all 3 radiographs, period. All right. I don't know. I guess I don't like it. I don't like it. I wouldn't cut the cat right now, but he's eating foreign material. He's got a segmental distribution. This loop's kind of getting a little bit too big. So that's what I got. I wonder if this is like the corrugated duodenum up there, but you can't be certain. I'm looking at this. I kind of see something through here. Probably should do an ultrasound. But most of this resembles food to me. And it just happened based on the history, and there's some nice form feces. So kidneys are good. Kidneys on a neutered cat, 1.9 to 2.6, the length of L2. So you can just go like T13L1, L2. I'm lazy about it. You could just sort of get out your calculator. This is 2, and that's 2. So 1.9 to 2.3 or 2.4. So this is fine. This is over 2. And then neutered cat can intact cat can get up to 2.6. What are we looking at for on ultrasound? I want to make sure that there's not a foreign object that I just can't see. I think this case for me, if this was my own cat, I would just say, let me fast him. And then if he doesn't vomit, I like the fasting repeat rad situation in cases where they have stuff in their stomach, because if you hold this cat for 8 hours, 12 hours, and he doesn't vomit and this stuff is gone, I mean, then this probably will resolve. So if this is gone, he hasn't vomited, it's got to go down. And so I like that because you can compare the size of the stomach, you can compare the small intestine, and the character of the feces will change too. And so you can compare these sort of apples to apples. And I really like that. If the stomach was empty and I was hemming and hawing about maybe some of the small intestine being too big, then I think it's sort of less helpful. But I love when there's stuff in the stomach and then you're not really convinced that he's obstructed, but maybe you're a little bit worried. If he's vomiting, would you say maybe ileus? So I don't use the term, I still don't use the term ileus, because I think, and maybe it's just me, but I think there can be universal confusion. There's the mechanical ileus, there's the functional ileus. One of the reasons I guess that I'm giving a little bit of pause for this case on saying like, oh, he's definitely obstructed because we've got this, is because I've over the years played the game of, is the animal presenting for GI signs or urinary signs? And in cats, I'll pop up the thing. I'll go, holy shit, this looks like he's going to have GI signs, and he's eating and fine, and he's got hematuria. And so I feel like you got to chill out sometimes when you got a stomach that looks like it's full of food. And yes, you have these loops are too big. But I think we've got a little bit of time, and I think we should probably just, you can either ultrasound them now, make sure you don't see a foreign object that's causing this. I would be surprised, I guess, if we do. And then I think the follow-up rad plan, I think, is great. Graham asked about any rules of thumb for small intestinal dilation. I think if you've got a segmental dilation, and again, these are rules of thumb, I don't think they should be etched in stone, but a cat 1.2 centimeter or 12 millimeter is a rule of thumb for pathologic distension. And so this one is, I think it was, what I get, like 1 serosa to the serosa, best you can do it. So this is 1. So it's not even hit that threshold that we sometimes will use. So I think we've, but it's too big. It's too big. He's got a bunch of stuff in his stomach. They've just told me that he's vomiting foreign material and he eats foreign material. So I think it's totally justified to make sure that these loops right here, there's something that's not like hiding in here, causing an obstruction. This is probably part of the colon. I think the colon goes down here, comes up through here. So this is small intestine here, and this is small intestine here, and a bunch of this is small intestine. And so I don't really get the plication feeling here. I don't really get the plication feeling here. So the anchored foreign object with the linear foreign body, I feel like maybe we're okay. But I think that's why this is a case. I think the take home for me is I would not cut the cat right now, but I would not just say bye. I would say we got to do something. We need to come back. We need to either fast him, support Serenia, subQ fluids, whatever, fast him, repeat the rads. How's the stomach look? How's the small intestine look? What do the feces look like? How'd the cat do? Or if you have the capabilities, you can hold send them now. And I would be looking at the pyloric outflow. I'd be looking at this. Can I get the PDJ, pyloroduodenal junction? And I'd be looking at these small intestine. I'd be running it and seeing, do I see any foreign object that would make me say, okay, we should reconsider what we're doing. Okay, I finalized it. We're done. Here we go. Next case. Any questions? Was that fun? You want me to go back to known cases? We like doing these cases. No, you're right. Typically, you'll pool fluid within a if you have a mechanical obstruction. If you have a mechanical obstruction that's going on near 24 hours, you'll start to get fluid influx into the gut, and so you will have this mixture of fluid and gas in segmentally distended loops. So you didn't make that up. I think that's a good rule of thumb. All right, so we've got a 10-year-old canine. So 10-year-old, says female intact. Sometimes that history that I get is wrong. So female, spayed, female intact, or entire, as some of you say. Presents for chronic cough, chronic nasal discharge, mild to moderate, consistent shallow cough, and current right-sided clear with minimal mucus discharge. Patient has been on antibiotics in the past and no resolution. Okay, we got 3 views of the chest. We've got a right lateral view. We've got a left lateral view and, VD view and a left lateral view. Okay, so I'm going to give you guys, I've never seen this case, brand new case. This was submitted November 20th at 1 a.m. 3 thoracic radiographs are dated November 17, 2023 period. So these are dated the 17th, but we got them overnight. So sometimes they can take a little bit of time. We'll pass you over the 7th rib. 7th rib, 1, 2, 3, 4, 5, 6, 7. So here we go. I'm going to just dictate this one, and I'll just show you how I do it. New line. The patient is obese, period. The cardiac silhouette is normal, period. There's no evidence of left atrial enlargement given the absence of loss of caudal cardiac waste, period. The trachea is normal in luminal diameter and course, period. The cranial mediastinum is within normal limits, period. The vague opacity near the second sternobra on the left lateral view may be fat and overlying thoracic limb, period. There is no concern for sternal lymphadenopathy on the additional views, period. The cranial abdomen included on this test is normal, period. The stomach is mildly gas-filled, period. Thoracic lymphadenopathy is absent, period. The cranial mediastinum is within normal limits, period. The pleural space is normal, period. Moderate elbow joint osteoarthrosis is likely right-sided, given that the contralateral limb is magnified, period. The lungs have a mild diffuse bronchial pattern, period. On the right lateral view, near the cardiac apex at the level of the 7th sternobra, there's a faint increase in soft tissue opacity, likely in the caudal subsegment of the left cranial lung lobe, period. On the left lateral view, there is a patchy alveolar focus near the cardiac apex in the vicinity of the right middle lung lobe, period. The costochondral junctions are mineralized and contribute to the opacity in this area, period. The lungs lack soft tissue opaque nodules, period. A collection of mineral is adjacent to the right shoulder joint, period. This is not included on the orthogonal view, making further localization challenging, period. This could potentially... This is a bit larger than expected for the clavicular remnant, period. Biceps mineralization is possible, period. Cap this. 1, period, mild diffuse bronchial pattern with low-grade pneumonia. low-grade right middle and possibly concurrent left cranial lung pneumonia, period. The more widespread bronchial markings could be an incidental aging change, period. The chronic cough, non-responsive to antibiotics, could be an indication the patient has underlying lower airway inflammation, such as allergic bronchitis, period. Perhaps the patient has chronic allergic bronchitis that is now complicated by low-grade pneumonia, period. Inhaled irritants and parasitic pneumonitis are perhaps less likely, period. New line 2, period. Obesity. New line 3, period. Moderate elbow joint osteoarthrosis, common likely right-sided. Okay, anybody else think I'm full of shit about the pneumonia? It's subtle. There's just something right here. I think we could talk. This whole area, there's so when you look over the cardiac silhouette, I was trained, it's been my experience, and hopefully you can gather from this that if you see anything that's opaque overlying the gray of the heart, if it's opaque, it better be a blood vessel or a rib or potentially a thickened airway. And so you go, there's a blood vessel. This is all gray. This is opaque, but there's a rib. That's a blood vessel. That's a blood vessel. There's this funk down here. Now, could this be fibrosis or atelectasis, cicatrizing atelectasis, like scar tissue from previous pneumonia? Sure. Could it be atelectasis from mucus plugging now? Sure. But I just don't like the way that it looks. I think it's low grade. I think there's too much opacity here. This whole area, so there's rib here and rib here, but this area kind of cheating through here, it should kind of be more gray like this. The trouble with this is sometimes you'll see the dependent lung pathology. Sometimes it'll shine through. And so then it's hard if you don't see, and to be clear, like I don't see either of that disease on this VD view. So I don't know if this is in the caudal subsegment of the left cranial lung lobe. Because see, you got the trachea or the trachea, it comes down here, okay? And you get a J hook right here. You can see it. It comes right here. You get a J hook. Boom. And then it kind of loses, but there's this J hook right here. So this J hook is this is a right lateral view, right? The crura of the diaphragm are parallel on a right lateral view. Trachea comes down, it hooks here and hooks here. So this is to the cranial subsegment of the left cranial, and this is the caudal subsegment of the left cranial lung lobe. This bronchus right here is the right cranial. It comes off at a sharp angle. Okay, so these walls are a little bit mineralized, whatever. I think I've talked about bronchial patterns are assholes because everybody's got one, but it's this stuff that's kind of funky. The other thing that they shouldn't rule out is also, given the signalement, consider ruling down concurrent laryngeal paralysis, period. Okay. Anybody have any concerns, issues, comments? That's a hard one, I think, but it's real. I don't like it. They should treat for pneumonia. The thing is if you want to miss something, miss a pulmonary nodule, miss a MET. The dog's not going to die because you miss a MET. He's going to come back in 6 weeks or 4 weeks, and he's going to have more of them. But if you miss pneumonia, I feel like that you could be up a creek. Explain the rule out for laryngeal paralysis. Just trying to be helpful. I don't know. I feel like sometimes that like this bronchial pattern doesn't bother me a ton. And so maybe he doesn't have lower airway disease. I think he's got some pneumonia. So I think he's not feeling well and he's on the table getting radiographed because he has pneumonia. So I think we should treat him for that. But I don't want him to go on this wild goose chase for chronic allergic bronchitis to explain the soft cough or the chronic cough and sort of miss laryngeal paralysis. So to me, it's a little love letter to the referring vet. Like, hey, I don't see really anything aside from pneumonia that could fit with LARPAR. The degree of esophageal dilation is trivial and probably normal or related to aerophagia. So just putting that nugget out there, hey, just double check there's no stridor, things like that. Hadn't they already tried antibiotics? Yeah, but the thing is like we get these. This is all happening sort of in a vacuum. It's tried antibiotics, but maybe it didn't have pneumonia previously. Maybe it had allergic bronchitis previously, and they tried antibiotics and it like didn't work. And now the dog has pneumonia because his chronic allergic bronchitis isn't being treated, and so maybe he needs antibiotics now. So I think one of the things that's different between reading in a vacuum in teleradiology is you get such limited information. Circular opacity on the right lateral view just an end-on blood vessel, circular opacity. This, yeah. So one of the things you got to be careful is this. Anytime you see nodules or what appear to be nodules that are up near the hilum of just all the blood vessels in the lung hilum up here, you got to be careful, and especially when you know that blood vessels have to kind of shoot out this way. So that's a blood vessel, that's a blood vessel, that's a blood vessel, that's a blood vessel, that's a blood vessel for sure. That's not a met. There's no way. Mm-mm, no way. See, and then you go, oh shit, that's kind of like in this area on the other view. So I think it just squirreled out and came at you or went away from you. And so it got a little bit more round. Okay. Look at all this. We got so much like we've got so many. This is what I was hoping, that you point out stuff that I just am ignoring. And that's the good stuff, because you're gonna be like, ah shit, he's got a met. Farmer quote, give it some strong antibiotics. Yeah. But if you're from Indiana, you say just give it some strong antibiotic. Give it some of that. If the opacity, right, seventh lateral incidental, is the opacity rib 7 right lateral incidental? Probably talking about this. I don't see any pulmonary nodules in this dog. I don't see pulmonary masses. I don't see pleural fluid. I don't see tracheobronchial lymphadenopathy. I see a bronchial pattern, which I think, like, a dog this size and this age would be totally par for the course. But I see some funk down in these lungs, and I'm worried about pneumonia. And I'm like, well, maybe he's got something else, because to lose comment, he's tried antibiotics. So maybe there's something going on to explain the sort of chronicity other than just incompletely resolved pneumonia. Maybe he's got LARPAR, maybe not. Maybe he's got allergic bronchitis, and maybe not. But this is all I got. Okay, there was a question, NY. Where are you? Okay, thanks. Got you. Here we go. Other than just knowing colon's general location, how can you be sure it's not dilated? I mean, that's the game. That's where it's tough. Yeah, I mean, the way that I think, if you listen to the way that I described the technique that I use, I go stomach first, then colon, because those are sort of the stomach is definitely the easiest of all three of them, because it usually is in the right position. And then the colon tends to be the next easier one, because then once I've located the colon, I know everything else has got to be small intestine. But that can be hard, because this colon goes down here and it dips, and then it comes up, and then it comes at you, and then it comes back this way. The other thing is just how the colon should make turns. So you wouldn't expect the colon, the colon comes up like this, and it does your sort of question mark sign. So I know that the colon doesn't, in this part of the abdomen, make a caudally convex turn. It just doesn't do that. And it doesn't make a caudally convex turn sort of anchoring down this way and coming forward. So it can be very hard, to answer your question. I mean, it can be very hard, and it can be a really, it can stress me out, because I don't really like suggesting other tests like pneumocolonograms. I like to try to be as committal as I can, because this cat's obviously gone, and nobody wants to do a pneumocolonogram on a cat or a dog or anybody. So I like to try to commit, but sometimes you don't know. So this is colon, dip, colon, coming at me. So it's probably this area right here, and then it loops around here. And I don't really see colon over here, because I think it's superimposed with the other part of the colon. But I know that the rest of this is a pathologically distended collection of small intestine. Maybe fungal. I mean, I don't usually start talking about the fungus until, there's miliary patterns like blasto. I see nodules. I see, I get a history of a location. This patient's in California, and so out in there, I'd be worried about coccidiomycosis, which would be giving you tracheobronchial lymphadenopathy. So it could be fungal, but I don't like to start talking fungal until it starts having nodular pattern. Let's see what we got here. So 3 views, November 19, 2023. Well, this sucks. We gave the cat a bath. Do you guys want to do this one, or you want me to find another one? It's kind of shitty. I mean, I think it's potentially a cool case, but this is just like wet. It's a thin, overexposed, wet cat. I'll just do it. I'll show you what I'm talking about, maybe. Okay, so we'll just do it. We'll do it. How about we'll do it and I'll just dictate this one. Maybe we'll kind of go. This is an 18-year-old Berman weighing in at 2.8 kgs. Female spayed, hyporexia, vomiting, not eating the past couple of days. Pink drops on the floor. Wasn't sure if it was urine or vomit. Patient's stomach was spasming, contracting a lot while she's resting. This poor cat. Historical kidney disease, receiving some fluids every day. So problem list, hematuria, history of CKD, historical azotemia. It seems like we got some vomiting. We're not wanting to eat. Okay. We don't have an ultrasound of it. Did they ultrasound it first? No, I don't think so. You mean like a fast scan or whatever? Focused assessment? Or like a full on? Boy, they got a good VD, huh? This shit's on fire. Look at these guys. I love it. Veterinary nurses are it, man. This cat's probably trying to die, trying to bite him. Easy, Ure. I like what you're talking about. Yes, dude. Yes. 3 radiographs are dated November 19, 2023 period. New line. The caudal thorax is normal period. The patient is thin period. The lumbosacral disc space is collapsed with end plate sclerosis. Opposing end plate sclerosis and incompletely bridging ventral spondylosis deformans period. The liver is normal period. The urinary bladder is small and fluid opaque period. So on the right lateral view, you've got the right kidney right here, and you've got the left kidney right here. And when you use this view, you may say, oh, well, there's some renal asymmetry. So the right kidney here is smaller than the left kidney, but you have to be a little bit wary of some magnification. So the left kidney is up and it's further away from the table, so it's going to look bigger. However, the animal is 2.5 kgs. So here's the left kidney right over here. The kidneys are like, right kidney is somewhat small period. The left kidney is normal to perhaps. The kidneys are somewhat small, and the right appears a bit smaller than the left, despite accounting for differences in recumbency period. The stomach has a small amount of amorphous soft tissue with admixed gas period. The colon contains a small amount of formed feces and gas period. The small intestine is uniform in size and normal in course, but appears either uniformly thick-walled, fluid-filled, or both. Period. Abdominal serosal detail is adequate. Period. The ventral abdominal hair is wet. Period. Dorsal to the colon at the level of L6 and L7. There is a loss of retroperitoneal serosal detail characterized by soft tissue opaque wisps. Period. The colon is displaced ventrally at this location. Period. Perhaps the descending colon is displaced to the left of midline on the VD view. Period. The hip joints are normal. Period. On the right lateral view, caudal to the left kidney, there is somewhat of a tubular structure, though it is difficult to determine if this is a ureter or a component of the loss of retroperitoneal serosal detail. Period. 1 period, mild bilateral chronic renal disease. New line 2 period, loss of caudal retroperitoneal serosal detail. C comment. New line 3 period, diffuse enteropathy. Consider causes of enteritis to include primary inflammatory/inflammatory bowel disease, dietary intolerance/indiscretion, toxic, infectious/parasitic, or a combination. Period. Small cell lymphoma should not be entirely excluded. Period. New line 4 period, thin body condition. New line 5 period, degenerative lumbosacral disc disease. The loss of retroperitoneal serosal detail could be the result of hemorrhage, urine, or possibly severe lymphadenitis or metastatic lymphadenopathy with regional steatitis. Period. A discrete mass is not identified in this region, however. Period. A Primary neoplasm, such as a retroperitoneal hemangiosarcoma, is not excluded, period. The adjacent osseous structures lack evidence of osseous reactivity, period. Abdominal ultrasonography is recommended at this time to not only evaluate the kidneys and small intestine, but also the retroperitoneal space, period. Okay, well, kind of a weird finding, but this is I think the one thing that caught my attention. The reason this is kind of a shitty case is because this wet hair, all this wet hair, it will cause streaking, and so it'll make you think that you've got a loss of serosal detail. But one of the reasons that I think this is real is because despite the degree of streaking, which is sort of covering all of the belly, I still see really good serosal detail through here. And so even though the patient is thin, one of the things, if you have a thin patient, you go, oh, well, there's a loss of serosal or retroperitoneal serosal detail because of a lack of fat to cause differential attenuation with the soft tissue. But you can use internal reference points. So you can oftentimes compare the retroperitoneal and peritoneal spaces. And so to me, despite the patient being thin, which will reduce the serosal detail, despite the patient having a wet hair artifact, which can contribute to a loss of serosal detail, despite those, I still think that peritoneal serosal detail is pretty good, but this is not good. There's like streaking through here. This is fat. This is fat. Like you can see this caudal margin of the left kidney, but this is streaking through here. I should be able to see more fat. And also this is displaced ventrally. One of the things that can displace this ventrally is a rotated patient, but he's pretty damn straight. And it persists on the lateral views. So there's something sinister here. There are sublumbar lymph nodes. The medial iliacs are in there. So I don't like that. Hopefully I addressed that, Lou. Yeah, lack of serosal detail, but I was able to walk through this and go, you know what? I don't think that this is. I don't think this isn't related to a spurious or incidental. I think there's a sinister process to cause that. That's streaking. We see that when we do ultrasound first and then x-rays. So now I do x-rays first. Yeah, I mean, this can be hard to do. I mean, hard to see, but yes, I would say this is subtle. I would say that this is subtle. Yeah. And this patient didn't get any favors by being wet, though. I get it. You can't you can't have a salon in there drying the cats off and then taking rads. You got to get what you can get. So I don't like this. This is going to hurt. My guess is he's got caudal abdominal pain. So, but you're going to go, oh, it's hematuria, shit, it's bladder, it's cystitis. And then, and I get it. And that's going to suck. And it's going to throw you because he's got hematuria. But that's something I don't expect you guys to see that. I don't expect that to be seen. I expect a radiologist to see it. And I expect somebody to find that on ultrasound. What's the soft tissue opacity ventral to L3-4 just above the gas? 765-434. This? Hard to know. That could be wet hair. I don't really think it's a nephrolith. I can't really see on this. I can't see on any of it. I don't know if you're talking about that. Could be a part of bowel overlying it. I think it's possible that that's a nephrolith in the caudal aspect of the right kidney. I can't see it here. There's a loop, a bowel that goes over here, and I can't see it. So left lateral. Oh, left lateral. What's the soft tissue opacity? Ventral to L3-4, 765-4334. Soft tissue opacity ventral to L3-4, just above the gas on the left lateral view. Here? This is a kidney. I think this is part of the kidney. Part of the kidney, colon, intestine, part of the kidney. There's the other kidney. This is GI loop, GI wall. This is a kidney. And this is the other kidney. Yeah, this whole thing's the kidney. It's right here. Open prin right, smaller than left, closed prin. Oh boy. Let's see what else we got here. Teeth. You gotta be kidding me. Teeth? We're not doing teeth. No teeth. The teeth are either present or they're absent. Give me 1 second. I'm gonna stop sharing because I gotta find this case. Okay, 5-year-old domestic long hair. We're gonna play the game. Okay, I'm not gonna tell you why he's here. GI or urinary. 3 views. Right lateral view, left lateral view. Left lateral, right lateral, VD. Start with the VD. 6-year-old cat, medium, I don't know, domestic long hair, male neutered. GI or urinary? Got a VD, a right lateral, and a left lateral view. I'm going to start with the VD. 3 radiographs are dated November 19, 2023 period. New line. The patient is obese period. The spleen is mildly enlarged period. The kidneys are normal period. The liver is normal period. The urinary bladder contains a small amount of fluid and amorphous mineral period. A focus of nodular fat necrosis in the caudal abdomen, superimposed with the urinary bladder and colon on the lateral views, particularly the left lateral view period. The stomach has a large amount of amorphous soft tissue and a smaller amount of gas and mineral period. The colon contains warm feces and gas period. The small intestine is uniform in size and mostly gas-filled period. Some small intestine in the caudal abdomen is corrugated period. Abdominal serosal detail is adequate period. The spleen is mildly enlarged period. 1 period, urinary bladder mineral debris / minute calculi. New line 2, period obesity. New line 3, period caudal abdominal incidental Bates body. New line 4, period splenomegaly dash. Consider congestion from sedation if clinically appropriate, period. Lymphoid hyperplasia, extramedullary hematopoiesis or other considerations, period. Round cell neoplasia, sequestration / consumption of blood cell lines, open paren, e.g. IMHA, close paren, and splenitis are perhaps less likely, period. New line 5, period. The majority of the gastric content resembles a recently ingested meal, period. This could contribute to the appearance of the remainder of the small intestine, period. The absence of GI signs makes enteritis much less likely, period. Okay, where's the Bates body? I think you guys, we got it. We got the fat thing, right? Fat pushing everything, So there's the Bates body. Here's the mineral debris. Okay, we probably got to do something about that. Maybe there's a calculus right there. I don't know. Period. On the right lateral view, there is possibly a minute mineral opaque calculus within the intra-abdominal urethra, period. This is not seen on the left lateral view, period. Okay, done. Boring. What was the history? Stranguria, hematuria, eaten fine. It's great. Feels great. Eaten very well. It's your classic, he's got UTIs before, he's got URIs, he's kind of like nervous, he's fluted, he's obese. How do you differentiate a blood clot in the bladder versus mineralization? Well, I can't. You mean if the blood clot ultimately develops mineral, like if it's more of a chronic clot, you can't. And I don't think it's, let's see. So you're asking a clinical question. I don't think you can. I'm not going to try that game. I think in this particular case, I don't feel great that this is a calculus. Maybe it's a calculus and it kind of, I don't know. I can't see it on the left lateral view, but I don't feel great. I don't see calculi, but I see mineral. That shouldn't be there. So either these are really tiny mineral and I just can't resolve their borders with radiography because of their small size, or it's just debris, or as we call sometimes debris. So if he's got debris in his urinary bladder, regardless, this is a problem. He's going to obstruct, re-obstruct. So maybe you catheterize him, you flush him. I don't know, prazosin, fluids, diet. But you could ultrasound. And the problem with ultrasound is you go, oh, well, there's all these like really tiny things and they overlap and they shadow. And you're like, well, now I don't really know. Yeah, I don't know if that helps. Yeah. So Deirdre, this is the game. You can't play this game as well with your own patients because you already kind of know. You could do it with a colleague where they just say, what do you think, GI or urinary? And so I play the game myself. I open these cases without the history, especially in cats. And I go, okay, I bet this. Sometimes it's easier because you're like, well, I see some funk in the bladder. And you're like, all right, I bet this cat is having some stranguria. He could also be having GI signs simultaneously. But you're like, all right, this is probably a urinary one. But I've just noticed that my ability is not as great as I would hope it is in order to say whether the cat has GI signs or not. It can be really difficult to tell. So I play the game, thousands of times, and then you kind of get a little bit better at it and you go, okay, I bet this is fine. But what it does is it also, when you start to realize that when you start to get worried about GI tracts in patients that don't have a GI problem, it should then give you pause in patients where you're maybe worried. So you think back to the other cat that we had, and I was like, look at this loop. See, this loop is not nearly as scary looking as that other one. But once you start to do that, where you go, is this GI, is this urinary, and you start to see these wonky GI tracts in asymptomatic patients, then when you're starting to dial in on is the animal obstructed or not, it can give you confidence to really chill out and maybe do a conservative follow-up test or go nuts and cut the animal. Yeah. So how do we rule out a linear form body? One, I can show you. Let's see. I got a locked cases. Right. Okay. So here, this is a problem. Right. So this animal, it's got fluid and gas. This isn't just gas, right? This is gas sitting on fluid. That's why it doesn't look so black like my soul. So black, this is like gray because it's gas sitting on fluid. This is a big ass stomach. This stomach swings way out here. Okay. So the other cat stomach was full of stuff, right? And so this is not good. And then when you look at the small intestine, you're like, everybody just looks stuck. Look at this. Beep, 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 beep. Everybody looks stuck. Like, what in the world? Look back here. My mentor used to call these mental wedgies. The fat just like, eh. Okay, so this is a normal turn. This is a normal turn. That's not good. This isn't good. Look at that. That's just like fluffy clouds, obstructed. This poor cat needs a surgeon. Okay, let's call it quits. Hopefully this was educational. Hopefully you got to practice your skills. Next week, I'm not here on Monday. We may do something on Wednesday. If not, I may put an hour on YouTube of GI obstructions or not. So I've got all those cases. I may just go through and say, what do you think? Obstructed or not obstructed, and give you the results. That can maybe substitute for a live stream. I'm headed back to visit my parents. So yeah,